All right, so I'm going to get started. If you have any questions or if you need, like, just want me to clarify something, feel free to unmute yourself or to put it in the chat box. Um, I'm going to try for this to be an hour long, but I'm happy to stay afterwards as for Q&A. Thank you guys all so much for joining tonight. So tonight we're going to be talking about the racial health disparities in New York City and what we can expect coming up with the coronavirus. And if you're wondering, how did she put together a whole presentation on racial health disparities and coronavirus already? The virus has just recently come to America. Well, most of the the first half of the information I'm going to be presenting is about racial health disparities in infant and maternal health outcomes. I'm a trained midwife, and I worked in the neonatal intensive care unit at SUNY Downstate Medical Center for the past 5 years, which is a segregated Black hospital in central Brooklyn. And I call it a segregated Black hospital because over 90% of our patients were Black, and the mechanism by which our population came to be that way was through residential segregation and illegal insurance discrimination, which we'll get to a little later on. So we're going to talk about kind of what we know already about how racial health disparities play out in those two fields and what they can tell us about what to expect, and hopefully some ways we can organize and prevent them from being large racial disparities in how we see the virus come through our city and state. So what we know right now about racial health disparities and maternal infant health outcomes is that Black women or Black birthing people are 12 times more likely than white birthing people to die of pregnancy-related causes in New York City. And Black infants are 3.3 times more likely to die before their first birthday than white infants are. And these disparities are the worst in the nation. So nationwide, the maternal mortality disparity is like 1 to, I think, 4 to 5, and the infant mortality disparity is 1 to 2. So it's significantly worse in New York City compared to other places. Most of the time when I'm speaking about racial disparity, I'm speaking just about what was happening at my hospital. So tonight that I'm doing a more broad presentation, I wanted to put in a slide just to kind of stop and explain a little bit about racial health disparities in general. And that is the very important concept that it is racism and not race that are responsible for these disparities. And what that means is that there is nothing wrong with Black people's bodies that makes them more susceptible to bad outcomes. There's no genetic difference between people who have African ancestry and people of European ancestry that would explain these drastic disparities. Dorothy Roberts speaks very well about this in her TED Talk. So if you're looking for things to watch and do while you're on physical distancing, I'd put that on your list. But the narrative that has been covered pretty well, I think, in the mainstream media has been how interpersonal racism factors into creating these disparities, with doctors not taking people's complaints seriously, with Black women's pain being dismissed, and that is super important and not my area of expertise. What I experienced and what I speak more to is structural racism, but I just want to put it out there so that if I didn't want to only talk about structural racism as if interpersonal racism isn't playing a huge role. But the thing I have to contribute to the conversation is about structural racism, and that's what we'll be talking about tonight. So we know that we see these huge disparities in New York City, and when we look closer at what is causing them, It seems to be about 3 hospitals. So Dr. Elizabeth Howell, who works at Mount Sinai, which is a large private hospital system here in New York City, published a study in 2016 called Delivery Contribution to Severe Maternal Morbidity. And what she did in that study was separate hospitals into 3 categories of low risk, medium, and high risk. So looking at how the outcomes were in relation to what you would expect for the types of patients that those hospitals were taking care of. So if a hospital was generally taking care of a sicker population, that was already factored in, and the study was to categorize as low, medium, and high risk was only looking at factors that are hospital dependent. And what she found when she put the hospitals in those 3 categories is that hugely disproportionately Black women were going to the most dangerous hospitals in New York City, and that the most dangerous hospitals in New York City weren't just a little bit more dangerous than the safer hospitals. They were more dangerous by exponentially. So there's a ninefold difference in the severe maternal morbidity rate between Maimonides and SUNY Downstate, which are like 7 miles apart here in Brooklyn. In 2018, Dr. Howell published a similar study that looked at the outcomes for very low birth weight infants in neonatal intensive care units, and found a very similar, essentially the same phenomenon, which was that, I didn't say it. So what she found with the severe maternal morbidity was that if Black women were going to hospitals that were as safe as the hospitals that white women were going to, the difference in severe maternal morbidity would drop by 47.7%. Okay, now we go to 2018, where she looked at the NICU outcomes and found again that about 40% of the difference in Black-white outcomes for very low birth weight babies, which are babies born below 3 pounds, that 40% of that was because of the lower quality of care delivered at a concentrated set of minority serving hospitals. Hi, I'm super sorry about that. Can everyone see and hear me?
Yes.
Great. One thing about living in central Brooklyn is that we don't have great internet infrastructure, and sometimes my internet cuts out, so I apologize for that. So getting back to what we were saying about NICU outcomes, so about 40% of the difference in NICU outcomes was because of the differences in care provided at hospitals. Okay, I'm going to skip over the national one. So what Dr. Howell's research is showing us is that about half of the difference, about half of the disparity in outcomes is because of worse hospital quality at a very concentrated set, so a very small number total of hospitals. What the research doesn't tell us, is which hospitals those are, and why the quality is lower there, and why care is so much worse there. And in the conclusion section of Dr. Howell's research, she says unable to determine. Well, I think it's relevant here to quote Marcel Pagnol, who Harriet Washington, this quote that I found through Harriet Washington in her book, Medical Apartheid, that a secret is not something unrevealed, but told privately in a whisper. So maybe these hospitals are anonymized in the research, but it is, for people who work within the hospitals in New York City, it is pretty easy to figure out which ones there are, because there's only a handful of hospitals that serve a disproportionate amount of Black people, and all of those hospitals have other public records of having very dangerous and unsafe care. The USA Today put out a database in 2017, which showed the percentage of birthing people at each hospital that were Black. And you can see that in Brooklyn, there's a 10-fold difference between the highest and lowest Black serving hospitals. Then when we look at the USA Today database also gave us the severe maternal morbidity rate for each of those hospitals. So on this map, what you can see is I ranked the hospitals from safest to most dangerous in Brooklyn, and then I plotted them on a map of racial ethnic distribution, and where red represents the Black population of Brooklyn. And what you can see is that the 3 most dangerous hospitals are all right in the center of segregated Black Brooklyn. And
hey,
again,
Katie, can you hear me?
Yes.
When we lost you, we lost the shared presentation, so you need to share it again.
Oh, thank you. Let me do that. Can you see it now?
Yep, it's back.
Okay, great. So here are the hospitals safest to most dangerous. They're plotted on the map of Brooklyn, 8, 9, 10, all in the center of segregated Black Brooklyn. And not just dangerous by a little bit, dangerous by a lot. So Maimonides has a severe maternal morbidity rate of 1.2, which is the national average. Every other hospital in Brooklyn besides Maimonides is worse than the national average for severe maternal morbidity. And Brookdale, Kings County, and SUNY Downstate are 6 to 8 times worse than Maimonides is. Also in 2017, Leapfrog, which is a hospital quality group, put out rankings for 2,639 hospitals, out of which only 10 got an F grade for safety, and SUNY Downstate and East Flatbush was one of the 10 hospitals nationwide to get an F grade for safety. If we look at a map of infant mortality, we see the same phenomenon where the districts with the highest infant mortality are the districts that feed into these 3 hospitals. So why is care so different at Downstate? Why is it so dangerous at these hospitals? Well, care is different because funding is different. And we'll talk about how funding is different in a minute, but because funding is different and we have so much less money than other hospitals, we just can't afford to hire the same staff. So we never have the appropriate number of nurses working, and there are multiple specialists that by state regulations, we don't have laws that say what should and shouldn't be at a hospital, but we do have regulations. And even though we have the state's, the state hospital is not meeting the state's own regulations because the state doesn't give us enough money to hire the staff to allow us to do that. And so, I think I'm often met with shock and surprise of like, well, how can that be? How are you passing your certifications? How can our NICU is a level 4 NICU, and we have to be designated that to be able to provide care to the sickest of infants. And we have that designation from the state. So like, how do they keep giving us this designation when we don't have the specialists to be able to provide that type of care? And the answer is racism. Like, there is no good answer to this. This is why there's a hashtag Black Lives Matter, because in many ways in American society, they haven't. So I guess so I don't have a good answer for how we have operated for year after year after year with such huge gaps in the staff and services we're able to provide, but we do. And if you want to read more about that and I have a whole PowerPoint presentation really just on the missing staff and services. But on my website, I have a a series of the emails that I was writing to my bosses about the complete absence of lactation support for parents in the neonatal intensive care unit, where breast milk is a life-saving intervention, and where the absence of lactation support and therefore the absence of almost none of the babies I cared for ended up receiving breast milk for a significant period of time. And that probably led to about 2 deaths a year from complications related to formula feeding. So this is the mechanism. And the fact that we are missing so many staff and services reflects, it kind of proves a theory within health disparities research, which is this idea of lag time. So health disparities within American history are almost never driven by Black people getting sicker. It's almost always that white people are getting healthier quicker. So we make a new medical discovery and it's available to white people first, and so white people get healthier quicker and the disparity grows that way. So on this graph, you can see that it took 40 years for the Black infant mortality rate to reach what the white infant mortality rate was in 1965. So if we go back to this list of all of the missing specialties within the NICU, NICUs didn't exist really before the 60s or 70s. So the science of how to keep very sick or premature babies alive is very new. And a lot of the discoveries of what we know keep sick and premature babies alive is research from the last 10, 20, 30 years. So if you have a hospital whose budget has been frozen by a state that's in austerity mode, when new discoveries come up, we are not able to implement them for our patients because it's not in the budget to do so. So the infant mortality rate at our hospital and in East Flatbush is 7 times higher than what it is in other areas of Brooklyn, but it's about the same of what it was in the best areas of Brooklyn 30 or 40 years ago. And so if we keep twiddling our thumbs and neglecting the funding disparities to Black serving hospitals, we will always see this disparity because the better financed hospitals will always be able to implement interventions earlier for their patients, and the lag time to get those interventions to the poorer funded hospitals will go on in perpetuity. So why is funding different at downstate? So there's kind of 3 levels of structural racism in the funding at SUNY downstate. And the first is the difference in private and public health insurance. So 2/3 of Black birthing people are on public health insurance or Medicaid, whereas 2/3 of white birthing people are on private health insurance through their employers. And private health insurance pays about twice as much for obstetric services than what public health insurance does. So what happens when you overlay the structural racism of low public reimbursement rates with the structural racism of residential housing segregation and economic disenfranchisement to those previously segregated neighborhoods, is you have hospitals with almost everybody is on public insurance, and so the money that they are bringing in is literally half as much as a hospital that is serving predominantly people who are on public insurance. This concept was introduced to me by an obstetrician, Allison Stubbe, who wrote this article after a Black Mama Matters conference a year or 2 ago. And she asked rhetorically, why is it considered acceptable to pay half as much for a Medicaid patient? And I think the answer is because we live in a country with pervasive racism and white supremacy. So Dr. Sadia Hartman, I should add doctor, hold on, she originated the concept of the afterlife of slavery, which describes slavery's persistent legacy of racialized violence that started during slavery. And in writing about the afterlife of slavery, she says, slavery had established a measure of man and a ranking of life worth that has yet to be undone. And I think, like, where more clearly can we see that than in public-private reimbursement rates? Because we are literally saying some people's lives are worth more to reproduce, some lives are worth more to keep healthy when they're pregnant, some lives are worth more when they're bringing life into this world. And what happens on the ground, on the labor floors, is a reflection of a structure that literally devalues or halves the value of many of the patients we are serving who are on public insurance. And I'll say it's not, sometimes structural racism is just the effect, and the original intent was not necessarily to hurt Black people. In this case, the initial intent was to hurt Black people, because when other industrialized, the United States was having a discussion about nationalized health insurance at the same time other industrialized nations were after World War II. And it was the segregated white American Medical Association, the AMA, who the first time they ever collected dues from their members was in this time to finance a lobbying effort against national health insurance, because the segregated white doctors who were members of the American Medical Association didn't want to have to take care of Black people. So in this intent, like, the intention was racist, and it is playing out to be racist. So the next level of structural racism in all of this is that the fact that public health insurance doesn't pay enough is tacitly admitted to within the structure of Medicaid legislation, because within the Center for Medicaid is a pool of money called the Disproportionate Share Hospital Fund. And that is money that's supposed to get doled out to hospitals that serve a disproportionate share of people who are on public insurance or Medicaid. So the issue, and in most other states, in Massachusetts and California, that's how the DSH payments are distributed. They are given to the hospitals that serve a disproportionate amount of people who are on public insurance. In New York, there's a law in Albany that separates the disproportionate share hospital payments into two pools, one for the public hospitals to divide into, and one for the private hospitals to divide into. And guess which one has 8 times more money in it? And guess who doesn't? And guess who serves about 8 times fewer uninsured and publicly insured patients? Okay, so there's really no explanation. The graph that we have in front of us, these orange dots show how much money that they are the hospital is getting from the government, and the blue bar shows how much money they are spending on un- and underinsured care. So you can see here the public hospitals run up tens of millions of dollars of debt each year caring for un- and underinsured patients, where the private hospitals are getting millions of dollars more than what they spent in the first place of just pure profit. And let's just remember, these private hospitals are nonprofits, so they are tax exempt. So they're just being given free money from the government to do whatever they want with. And there's, again, no real explanation for why this law exists besides government corruption and white supremacy. I think, the private, this formula benefits the private hospitals. The private hospitals have money to spend on lobbyists. I know some of them spend like $600,000 a year to lobbyist firms. The public hospitals, we don't have money for that, right? So when I have shown this graph and the report it comes from to legislators who are on the health committee, they're looking at me like, wait, what? The who's getting which kind of money from the DSH? And I'm like, wait, aren't you the legislator that passed this law? Shouldn't you, like, more than anybody else, know and understand how it's playing out? But I think local government is under-resourced and overwhelmed. Many legislators aren't health policy experts and don't necessarily understand the downstream implications for legislation that sits before them. And the people who are coming up with it, the only people that have the resources to write these kinds of laws and get them passed are the private hospitals that are using that power to rob the hospitals serving Black and brown people for their own profit. So another kind of just more about these, if I'm going to talk about issues at SUNY Downstate, I'll talk about issues at all of the hospitals. So more about the private hospitals. They illegally, all 5 of them practice illegal insurance discrimination. Just like last month, I was at the New York City midwives meeting and somebody stood up to make an announcement that Mount Sinai was launching a new center for maternal health of this, that, the other thing. And somebody raised their hand and asked, do you guys accept all insurances? And she said, right to a full room of midwives saying, well, people on public insurance are going to be seen by the residents, but we still will take them. Okay, so they'll be given to a doctor in training with poor supervision and probably no continuity of care because the structure of how we pay for healthcare in America tells the system that that person is worth less, and so they get less value care. So when they often within their own institutions will give worse care or segregate people on public insurance to get care at a different place within their hospitals. That's if they will accept people on public health insurance at all. A lot of times, none of our doctors accepting public insurance have any slots at this time, except for they say that to everyone who calls for years. The extra money they're getting from the government for DSH, they fail to tell patients that that money exists to help pay their bills and still put people still bill people these massive bills with no assistance. And unless the patient is savvy enough to investigate themselves to see that the hospital has a charity fund, they are often saddled with large amounts of medical debt. So I'm saying that, I've said that health insurance segregation is illegal. There's 2 federal, 2 state, and 1 local law that prohibit the practice of insurance discrimination. So if it's illegal, why aren't we doing anything about it? Well, we tried, and in 2008, the New York Lawyers for Public Interest filed a lawsuit to challenge the practice, except for the Attorney General of the state of New York at that time refused to take the lawsuit up. And who was the Attorney General at the time? Andrew Cuomo, who is our third term governor in New York, not term limited, who already has $5 million in his war chest for his next reelection campaign. Just more private hospital stuff. In the same year that the public hospitals racked up $1 billion of debt, they got about $1 billion of profit that, again, they don't have to pay taxes on. There are over 108 executives who got paid more than $1 million. There are over 150 executives at the 5 private hospitals that got paid more than the highest paid public official within the public hospital system. And then when you look at the population of who those hospitals are serving, you see that they are whiter than their surrounding neighborhoods. So disproportionately white, often pulling from wealthy suburbs while denying care to people within their immediate neighborhood. So if you just take a look at, I forgot to put the key in. Sorry, I'll have to put the key in for the next time you do this presentation. But there's a huge difference in who Bellevue and NYU serves. And those 2 hospitals are literally a block apart from each other. You walk out one door, walk 200 yards, and you're at the other hospital. So the first layer, public-private insurance. Second layer, the corrupt or inequitable way that disproportionate share hospital payments are distributed. The third layer of structural racism that is affecting SUNY Downstate's ability to provide good care is that SUNY Downstate is one of 3 hospitals within the State University of New York hospital system. The other 2 SUNY hospitals, SUNY Upstate and SUNY Stony Brook, which are in Syracuse and Long Island, the 2 of them are predominantly white serving, And both of them were getting $50 million a year in the state budget from at least 2016 to 2019. There's no project, there's no program, there's no explanation of things going on at those other two universities that that they should be getting this money, but SUNY Downstate not. If anything, SUNY Downstate serves the quote unquote neediest population, and we would need more funding from the state than those other two hospitals do. So when I asked the staffers of state senators who represent SUNY Downstate and the surrounding districts, their response to me of why Downstate didn't get that money was because Cuomo doesn't like Downstate. And so when a man born before, a white man who has an immense amount of power and was born before Jim Crow selectively withholds $50 million a year, which for context is 10% of our operating budget at Downstate. It's a huge chunk of our budget. Selectively withholds that, like there's no other way to describe that than white male supremacist governance. And so I think the last two things that I described, which is how New York does DSH payments differently than other states, and this extra layer of interpersonal, perhaps racism with Governor Cuomo withholding money from the state-run hospital, I think that may explain why New York has worse disparities than other states do, because New York City is racially segregated much more than, to a much larger degree than most other states are. Most other states don't have cities with this level of segregation, and most of them, even where there is segregation, they are using the DSH formula appropriately to maintain hospital quality at hospitals that serve a large amount of people who are on public insurance. I'll make a slide for later, but a report came out in this January about hospital quality, and New York State has the worst hospital quality of any state in the union. Like Mississippi, better hospitals than us. Alabama, better hospitals than New York. And if you're thinking like, that's crazy, what about New York Presbyterian and Columbia? Aren't those great hospitals? Actually, no. Pretty much all of the prestigious hospitals in New York, they get their, like the lists that they're on for being like top hospital for this, they're all the top hospitals for subspecialties. So like it's a top hospital for nephrology care. That doesn't necessarily, all of those hospitals have overall patient quality scores of 2 and 3 stars, where in any other major city, all of the best hospitals have quality scores, which look at things like patient infection rates, patient satisfaction. All of them have quality stars that are 4 and 5 for their best hospitals. It's only New York, like we are the aberration where the quality of care is so much lower across the board. And I think, again, it has to do with the different way we finance care. And then throw this into it is SUNY Downstate is a place that trains medical students, and more doctors practicing in New York City were trained at SUNY Downstate than any other medical school. So if you are trained in an environment that is incredibly dangerous and where low quality of care has become normalized because you don't have the resources to provide better quality care, and then you go out into the rest of the city, you don't just change on a dime because you're at a better financed or safer hospital with a more privileged population. You have been trained to do things poorly. And I think that is also an interesting way that, this structural racism is hurting everybody in New York. Okay, so this is more or less teaching that up until now is more or less the teaching I've been doing since last November, to try and bring attention to issues at SUNY Downstate. And the great news is that it kind of worked, or a little bit, in one of the Equity for Downstate schools, which was to get the $50 million restored to Downstate's funding. And while no state senators or assembly people came out officially in support of Equity for Downstate, many of them contacted the governor's office just to say like, hey, I have a nurse here saying you're withholding $50 million from the hospital. What's that about? And my hypothesis, which is Governor Cuomo took this money out of the budget because he could, and nobody would notice or say anything about it. And he was right for years. And when he stopped being right and people noticed and started asking questions, he just put the money back, because when the state budget was published in January, this line, SUNY Downstate, is right here along with it. So that is the work that I have been focusing on, was to get the $50 million and then to go forward to do prosecutor's reconciliation and reparations for the state perpetuated medical racism that is taking place at Downstate. But now coronavirus is happening, and I am incredibly concerned that the same pattern of poor hospital care contributing to racial disparities is about to play out on a massive scale with coronavirus, because SUNY Downstate, Brookdale, and Kings County on a good day are understaffed. And so what is going to happen when there's a massive influx of patients to these hospitals is like they already can't have the capacity. None of the nursing agencies that staff these hospitals have gotten in touch with me, and I'm on their listservs to say SUNY Downstate is trying to get more nurses because coronavirus is happening. From what yesterday, Governor Cuomo put out a call for retired nurses to register so that the state knows who's out there and who they could call on if there's a massive influx of patients. But we can't really trust Governor Cuomo to look out for East Flatbush, I think is hopefully become pretty clear through this presentation. So I'm so glad you all are here tonight to help me get the word out on this, because I think it is incredibly important that within the public narrative of health disparities, we are constantly talking about the connection between care quality, resource availability, and racial health disparities. This is my home office, and so you can see I have color-coded files behind me. All of the yellow ones are coverage of infant maternal mortality, racial disparities in infant maternal mortality for the last couple of years. I track this very closely, and pretty much there's stories that talk about hospitals having bad quality, but they don't mention that like 6 months earlier there was a huge budget cut. There are stories that talk about huge budget cuts, but they don't mention that there are potentially changes in care quality that will be associated later on with those budget cuts. There are articles about racial health disparities or about Black birthing people being treated very poorly within a hospital, but that narrative doesn't speak at all to whether the hospital staff had the resources or the capability to treat that person well. So if you read a narrative where the nurse is dismissing somebody's symptoms, well, did she have time to listen to those symptoms seriously, or did she have 3 times as many patients as she should have? And so the dismissiveness sometimes 100% is because that nurse is a racist, and I don't want to dismiss that. But there are also times where the nurse really wants to be able to provide good care and is unable to. And in many of the narratives of Black birthing people receiving poor care, there's no examination of whether the resources were there in the first place to be able to provide good care. And so you can see, like, when you start searching just by a hospital, you see it popping up in all of these different stories, but no one is connecting the thing together. So I think it's really important going forward that we follow the money and use kind of the same common sense that we apply to any other situation, which is if you cut a hospital's budget, they're not going to be able to do as good a job as another hospital. And if you want them to be able to provide as good care, you got to correct the funding disparities. And I think it's, I think I essentially am just waiting for a month from now for the initial studies to come out that are going to say, like, do people who have African ancestries genes respond differently to coronavirus because it seems like they're dying at twice the rate, and no one's going to zoom in and say, okay, well, everybody is understaffed, but at the whiter serving hospitals, it's 3 patients to a nurse, and at the Black serving hospitals, it's 10 patients to a nurse. So maybe that's why people are not pulling through the coronavirus. So lessons for coronavirus, the public narrative, and then now is where we're gonna start getting interactive, because so much of the problems that have been happening at downstate, I think, is because people is just what happens when people aren't paying attention, and that is, I need to correct that, because Black women have been speaking out about understaffing for a real ass long time and have just been ignored, and we can't discount the fact that the media doesn't cover when nurses protest, and people don't take nurses seriously when they speak out in ways where we can about understaffing issues. But so that being said, but I mean, that's still all a part of just generally most New Yorkers don't know what is happening at the publicly run hospital, at a hospital where the conditions reflect, essentially, theoretically reflect the will of the people. I think most people, when they hear the conditions that NICU babies were experiencing, are horrified and would gladly come to a teach-in or get involved to correct that care. And so the rest of this seminar should be learning some tools to help us pay attention, to help us key into what is happening in Central Brooklyn, and to connect us to the people who have power to try and get some interventions in place now that will prevent future disparities. So the first thing I would like everyone, I guess not the first thing, you guys already tuned in, but the thing I'd love for everyone to do now is to go to whorepresentsme.org and type in your address and find out who your state assembly and senator are. So if you, where's the chat box? Oh, shoot. Give me a second to find the chat box. Oh, here we go. So you can follow, send to everyone. Okay, so you can follow that link to find out who your state senator and assembly person are. And if you already know who your state senator and assembly person are, awesome. Go ahead and start looking them up on social media. So find them on essentially any platform you use: Facebook, Twitter, Instagram. Find their page, like it, follow their page, friend them, follow them on Twitter, follow them on Instagram. And something you may find when you go to do that is a lot of these people don't have a lot of followers, and you may be able to get in touch with them quickly. Just last night I had somebody tweet at their assembly member, and their assembly member tweeted back within like 10 minutes. Very cool. Sorry, I've lost the, oh, there we go. So now the next thing we're going to do is, once you know who your state senator and assembly people are, so following them on social media is great because you are able to get in touch with them, and also it helps key you into like what they're doing, what they're talking about, what they care about, what they've been working on. Okay. Oh, you can't see the slides. All right, let me put that back up. Are the slides back up? Oh wait, okay, that was an old thing. Oof. All right, is there anything we can do if we don't live in New York City? Oh wait, yes. Are you in, okay, so if you are not in New York, then you'll just need to think creatively about how this will apply to your state and your situation. This is pretty New York focused, apologies. If you are not in New York City, just go to Google and search like who represents me New York, and there's a different website that you'll find pretty easily for people who are outside of the 5 boroughs. And you type in your address and it will show you your state senator and assembly person. So the next thing we're going to do is find, so like a important skill once you're like when you're following your assembly person is to know what they support, what they don't support, so that you can, if you hear of a bill that's come out, you can, like, you are the best lobbyist for issues in your district. Your elected representative is most responsive to you as a voting constituent, because what keeps them in office is your vote. And so if you hear that a bill has come out, or, you know, especially with coronavirus, there's going to be things coming out all the time about an emergency relief funding bill for this, that, or the other thing. And you'll want to be able to find out, okay, is my senator signed on to this bill? If so, let me tweet at them and say thank you for supporting it, so that they know that that they are acting in line with their constituency and they keep voting in support of policies like this. Or if they don't support it, let me tweet at them and ask them to support. So the way you're going to do that is if you go to the newyorksenate.gov, search legislation, you'll see that it has this like advanced search thing, and you can kind of put whatever words, like whatever you're looking for in the thing. So if you see there's an emergency relief funding bill for workers, you put emergency relief funding bill and see what comes up. Usually within 5 minutes of either Google or of the official thing on New York State, you can usually find that bill. So the thing I want everyone to look up right now is whether or not their senator is supporting, their senator and their assembly person is supporting the New York Health Act. So if you go to nysenate.gov, search legislation, and I'll just copy paste that link for you all. And then you type New York Health Act, search. You see, boop, 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 it's the third one down, provides for the establishment of the New York Health Plan, Bill S3577. Click on that. And then here you see it is in the Health Committee, and Senator Rivera, who's the chair of the New York State Senate Health Committee, he is the primary sponsor in the Senate. And then here you can see all of the co-sponsors. And so what the co-sponsor, like what it means to be a co-sponsor on a bill, especially a big piece of legislation like this, is essentially they are voting yes on it in advance. So the leaders in the legislature are not going to call this bill for a vote until they know it is going to pass, because if it fails and gets voted down, then it's a super complicated legal process to bring the bill back up again, or to bring the idea back up again. So what activists have been doing for years now is to ask senators to be a co-sponsor of the legislation, which is, you know, a public affirmation of them supporting it. And we have one less co-sponsor than we need to have the majority of state senators on the New York Health Act, which is New York State's Medicare for All bill, which provides universal guaranteed health care with no deductibles, no co-pays for every person in the state of New York, regardless of immigration status. And so the reason why we are focusing on the New York Health Act in this interactive part is because when we talk about the 3 levels of structural racism at SUNY Downstate, 2 of them go away once we go to single payer healthcare. So the differences in private public insurance go away if there's no private public insurance anymore. And the inequitable way the DSH money is distributed doesn't matter if everybody is on the same insurance. Some people have argued, well, like, if public insurance doesn't pay enough, won't it just be an apocalypse if we all go to public insurance? Well, I'm hoping we don't have a death wish in that if we all vote for public insurance, we vote for a public insurance with reimbursement rates that are tagged to the cost of providing quality care. And one of the reasons why it's so important we're all learning these civic skills of looking up of being able to know what our elected representatives are supporting or not supporting, and being able to get in touch with them quickly is so that if we do go to the New York Health Act and asthma care isn't being reimbursed well enough and asthmatics just across the board aren't getting good care, we'll need a way to get in touch with our legislators and say, hey, we need to change this and fix this quickly, so that everybody gets good care. And hopefully it works out, because instead of it, like right now, there are some people in the state of New York who are getting good health care. And those are people who have, the money, the connections, and the time to do policy work. And for the most part, the people who would be able to advocate about hospital conditions are not in the hospitals and do not know about the conditions that are the downstream effect of current policy. All right, so let's go. What else did we want to do? So, okay, oh, right. Go back to here. Okay, so so you can, after you look up who your state senator is and you see, are they signed on here or are they not? Now, to find if the assembly member is on, you can see that every bill, if you look it up in the assembly, it's going to say, see the Senate version here. And if you look it up in the Senate, it says, see the assembly version here. So you can click here to see the assembly version of that bill. And again, you can see the primary sponsor is Richard Gottfried, who is the chair of the Assembly Health Committee. So he's Senator Rivera's counterpart in the state assembly, which is analogous to like the federal Congress. And then the co-sponsors, there's a whole bunch of them. There's 150 assembly members in the state of New York, and most of them are, the New York Health Act has passed the assembly many years in a row. And it was only last year when it got close to being able to pass in the Senate that the assembly didn't vote for it at all. So as it stands now, the state of New York is 1 vote away from having single payer health care, and we are entering an effing pandemic. So like, there's literally not a better time for us to vote and pass this and implement it. Like if tonight we all start tweeting about this and it sets off a tweet storm, and the Democratic holdouts and the people whose vote we need to get to pass this wake up and they're like, oh, I'm convinced now, I'm gonna vote for the New York Health Act. If any one of the 9 holdouts does that, and then the Speaker of the Senate and Assembly bring it up for a vote, it will pass. And I think there's like a 120-day rollout period, and the pandemic is like just going to be getting started in 2 or 3 months by some people's predictions. So here is a bill that could we are in a very unique situation in New York that this bill is already written, has already gotten so close to being able to pass. So I'm obviously in no way happy to have a pandemic, but I am happy that, not happy, I'm hoping that this could be an event that pushes us to adopting single payer health care. And I think there have been innumerable articles in the past couple of weeks that make the case of how dangerous it is for everybody to have anybody within a society that doesn't have access to health care when there's something like a contagious disease going around. And I think it's just as dangerous, honestly, to us socially, to have ignored these needs, even if it doesn't even if we can't catch a disease, I think it damages us on some psychosocial, emotional level to live in a society that lets people die when we have the resources to be able to do so otherwise. Okay, so we looked up your people. We saw if they're on the New York Health Act. I mentioned that we have holdouts. So the Democrats have a majority in both the Senate and in the Assembly in New York right now. So we don't even need to convince a Republican to vote for the New York Health Act. We just need to convince any one of these 9 Democratic holdouts. And so if, does somebody have a question? So if you have Twitter, log on to Twitter right now because we're going to do some real-time advocacy. If you do not have Twitter, find your legislators on the platform of your choice, and we are just going to, if you don't have Twitter, you're going to leave one of these 2 messages. If they are a co-sponsor of the New York Health Act, you're going to send them a little message that's just thanking them for being a co-sponsor and asking them to prioritize passing this legislation in this time. You know, all of these people work together. So it's the kind of thing that even if they are a co-sponsor, if they're getting calls every 5 minutes saying, thank you for doing this, but please get it passed now, they're going to turn to the legislators who are not signed on to it yet and say like, hey, come on, James Scoofus, like my constituents are calling me every 5 minutes. When are you going to sign on to it? So if we, by putting pressure on, there's a good reason to put pressure on people who support and don't support it either way, because we definitely, you know, we need for this to be at the forefront of people's minds. You know, people are talking about like stopgap measures of like, oh, well, we'll give everybody healthcare for just this one disease. Well, let's use this momentum to get everybody healthcare for everything going forward. If your legislator is Felix Ortiz or Senator Gustavo Rivera, both of them, since the pandemic have started, have put out calls to say, because this is a pandemic, pass the New York Health Act. So if you're either one of Felix Ortiz, who's in the Assembly, or Senator Rivera, you just straight thank them. You don't need to ask them to do anything. They're, you know, they're out leading the fight. And then if you have Twitter, what I'd also like you to do now is you can follow the link I just sent to the text box to get this tweet from the Campaign for New York Health, which is like the official campaign headquarters for this bill that one person works for. So they do a fantastic job, but super important for there to be grassroots activism as well. But they put out this infographic about how the New York Health Act will help us respond to the coronavirus. So if you follow that link to get to the New York Health Act, what you can do is retweet it, adding all of the holdouts. So there's all of their handles I just sent through to the chat box. And this tweet will work. What I just sent through is right character-wise, but feel free to mix it up and to put your own message in. So if you have Twitter, go ahead and get in touch, or, you know, so everyone get in touch with your own reps to thank and ask them to support it. And if you have Twitter, go on to Twitter to tweet at the holdouts and say like, hey, now's the time. Now's the time to give your support. I'll point out specifically James Scoofus and Gargrin for Senate. Both of them campaigned saying they would vote for the New York Health Act. So not cool that they are not supporting it now. And I guess I'll just copy paste the text of these other ones. So feel free to, I really just wrote these out because I know some people get nervous and it's easier to copy paste things, but it's probably better to put things in your own words if you want to put things in your own words. Let's see. Then, okay, so now I have a lot more ideas of how to use Twitter for activism. So tune in on Friday at 4 p.m. and we're going to do a live Twitter action that's similar to this, where I'm helping like teach people how to use Twitter. So if you don't have a Twitter handle at all, I'm going to go slow. People can ask questions and you can like watch me do things from the screen. But especially with physical distancing, like we can't really protest right now. I think this is the best way, and this is the way that lots of effective activists have gotten things through, by making their presence known through social media. So learning how to use Twitter, even if it's in this very narrow way of connecting with our elected officials, is super helpful. I mentioned before that a lot of them don't have a lot of followers. So every time you @ them at Twitter and it gets retweeted, they get a notification. So, and most of these legislators have like 4 to 7 people on their staff. So if they don't operate their account themselves, the person who's operating it works pretty closely with them. So like if I tweet something at them, the person who operates their account is just going to roll their eyes and be like, oh, right, this is this crazy nurse that's been tweeting us for the past year to tweet the New York Health Act. But if I tweet at them and 15 other people retweet me, then they're going to say, oh, hey, we got 15 tweets at us today about the New York Health Act. Maybe we need to think about that more seriously, or move on that. So okay, let me just go back to lessons learned for coronavirus. Okay, so we need to pay attention to state government because, like, I guess I can't tell you now what we need to do going forward because things are moving so quickly, but we all need to be paying attention that this could be an issue. Also, just like the conversation before the pandemic got really more serious in New York was about like $2 billion in Medicaid cuts. So like, even, right now we need to be putting, even before a pandemic, we needed to be putting more money into Medicaid, and Governor Cuomo was talking about taking money out of Medicaid. And the pandemic has not really changed the rhetoric coming from Albany about coming up budget cuts. So some legislators are really out in front saying tax the rich. New York has over 100 billionaires in New York. There are over 44,000 multimillionaires in New York State. We have all of the money we could ever need to do any kind of social program we could ever want to do right here in the state. And we have a Democratic majority in the state legislature to get that money from them if we're exerting pressure and if we're making it very clear to our elected officials that we will not accept austerity measures while there are so many rich people here in the state. And then the last thing, so Equity for Downstate, the campaign that I had started to focus on the $50 million, we were shifting gears to start working on truth, reconciliation, and reparations. And the main way that I wanted to do that is Assembly Member Charles Barron, who's actually one of the 2 legislators who's been diagnosed with coronavirus. He has a bill in the Assembly to start for a commission to make recommendations to the state for full reparations for New York State's role and New York City's role in slavery and racial oppression. And that bill only has like 32 co-sponsors of the 150 Assembly members. So the thought process with Equity for Downstate was to try and get Assembly members to sign on to the general reparations bill and build political power as we were getting in touch with these people, so that we could essentially, so the thought process, if they sign on to a general reparations bill, they'll sign on to a bill about state perpetuated medical racism when we had that ready. So that I'm kind of shelving right now because I think the much more important thing is for the city and state to appoint disparities are. I don't know if this is the best idea, and there are a couple of people on this call that are like public healthy people, and if you have better ideas or alternative ideas or other things you think we should be doing, please tell me. But my initial thought is like, at least we need to be putting somebody in power with a, you know, we need to be putting somebody with power and resources who is paying attention to the high minority serving hospitals and making sure that in our corona response that they are getting everything they need to be able to provide as good medical care as we could anywhere in the state for the pandemic, and that Central Brooklyn is not forgotten about, and that you know, the resources that are coming out for corona are not only going to the white areas of the state. And then so I'm looking for people, any New York resident. I haven't talked to any elected officials yet. So if you're on this call and you live in New York, I would love your help to get in touch with your legislator, essentially to do a Zoom meeting. Well, we'll go, I'll give your senator the same spiel I just gave you all, maybe a little shorter, depending on how much time they give us, and make that recommendation that we need to, you know, write a 1 or 2 sentence bill that says like X amount of money will be set aside to appoint a disparity czar for the next year to oversee this. And as we are talking to people about why we need a disparities czar, we'll also say like, and this summer, would you want to participate in a roundtable about truth, reconciliation, and reparations, so we can start writing a bill about for SUNY Downstate specifically. And I have like a whole presentation on what I'd want that to look like and about that. So I'll keep putting out teach-ins, keep tuning in. So what else before we go? Okay, so with that said, for those of you who are on Twitter, I tweeted this a couple of days ago. In the past year, there has been public reporting of 8 understaffing related deaths at 90% Black serving SUNY Downstate, and that was before a pandemic. There will be huge disparities if we don't act now. And then I have tweeted the legislators in Central Brooklyn who I think would be most likely to work with me on something like that. So if you can follow that through and retweet either or of those tweets, but probably better the one that has all of the assembly, or all of the legislators added, because by retweeting that, again, you're like making notifications pop up in their phone. And so if Tremaine Wright, that has 2,000 followers, gets 10 notifications, that may be most of the notifications she's getting in the day, and she's going to think, oh, maybe I should take this meeting with my constituent. Something I just want to put on people's radar is that Senator Salazar, who's the head of the Women's Issues Committee, and Assemblymember Kim have been working on something called the Inclusive Value Ledger, which would essentially create to be honest, I don't understand it well, which is why you'll see that I tweeted right below, hi, Assemblymember Kim, can you have a teach-in or a Q&A? But it essentially creates like New York City's own virtual currency that would be able to reimburse people for care costs. So like if you're taking care of an elderly family member, or if you're taking care of a kid, or if you are picking up groceries for a neighbor of yours that's disabled, the city would be able to pay you in a virtual currency that would be redeemable at various places. I think like be redeemable in place of food stamps. Okay, so like I said, I don't understand it well, but I think that it is, Assemblymember Kim has been out there saying, hey, this could be a great response to the economic outfall of the pandemic, is what if we can fairly compensate people for helping their neighbors out and for taking care of one another in non-traditional ways in this time, in ways that they can pay their rent and buy food and live their lives on. So if you can retweet that at Assemblymember Kim, if he sees that there's interest in a teach-in, he is more likely to host one. And then lastly, thank you guys so much for everyone who has participated in this tonight. The last thing I sent through is a form to a Google Doc, Google form. where you can put in the information I would need to get in touch with you to be a part of future actions with your state senator and assembly person. So what we have been doing, essentially, if I call and say, hi, I want a meeting, they're like, okay, cool. But if 10 people call after me, they're like, oh, if 10 constituents specifically call afterwards, they're much more likely to take me seriously and to take a meeting. So as I've been gathering people's information to make a database so I can find who specifically can get in touch with the legislators I need to be in touch with. So fill that out. And then there's also a bunch of different check boxes if you are interested in becoming more involved with the advocacy and activism work that I've been doing. I'll share like the vision I have going forward is to create some kind of reproductive justice and birth justice and grassroots lobbying organization where we have essentially what I would love to see go is to have 64 district leaders and 150 assembly district leaders of people who are all volunteers who are civically engaged, who are following their elected representative closely enough to kind of have a sense of what's going on with them and their priorities. And that is kind of the point person for people within their district that care about these issues, so that when people come to a teach-in and you want to get involved, I'll be able to say, oh, great, you live in so-and-so's district, and I can connect you to that district leader, and that district leader is going to give you like a little, this is, we met with our senator a couple of months ago. This is what he said. He was super helpful. He was super not helpful. We want to primary him. We don't want to primary him. And that way we'll be able to build power by each district in New York. And that way in the future, if we have an idea for a bill or legislation, we write it, and within hopefully a couple of weeks, we'd be able to contact every legislator in New York to get it passed, because we've been doing that type of organizing work. So if you fill out that Google Doc, let me know if you are interested in being like that type of district leader, of helping set meetings with your person and helping coordinate with other people who are in your district. I already have a couple of district leaders in Central Brooklyn and in the Bronx. So if I see that you are in a district where we already have a leader, I'll be connecting you with them. And pretty much all of our district leaders are also, I've been doing political advocacy work for like a year or two, and they're all like, a couple months behind me. So we're all learning as we go. And so they'll be glad to be connected with other energetic people who want to help and think through how to organize within the district. You'll see, I have your email, so you'll be getting emails from me. When you see I have events like this, it's a lot for me to like make the Zoom and send out an email and put it on my Facebook and put it on my Instagram and put it on my Twitter, and then hope people register and then share it again because people forget. So the more you can, even if you can't attend, if you can just say, I went to a teach-in and I learned a lot, you should attend. The more you share on social media, the better. Right now, it's pretty much only people who follow me who are seeing this stuff, and hopefully all of New York will have access to this information soon. I think every New Yorker should know what's happening in our public hospitals. What do I have here? Citizen reporters. So like read my blog, share the blog posts that I've written. I've talked to a lot of reporters that for one reason or another haven't been able to follow up on this, but like the more it gets out there through social media, the more people see it as a legitimate story to cover. And you'll see on the form it says Twitter team, and if you give me your Twitter handle, is essentially like right now it's 3 people, but if I'm trying to get a particular person's attention, I just send the link through a DM on Twitter, and people can retweet that tweet. So like immediately I can get get in touch with the person who I want to get in touch with. If you like scroll through my Twitter feed, you'll see like I tweeted at Seth Meyers to be like, I hear you're going on hiatus. Do you want to do a thing of the New York Health Act? And it like got retweeted once, which means you'll probably not see it. But if 50 people retweet it, even if you don't have a lot of followers, you may be like, oh, maybe I should do something on the New York Health Act. So fill out the volunteer interest form and then come back on Friday and we'll talk a lot more about how we can use Twitter and mobilize virtually in this time of physical distancing. So that's all I had to share with you guys for tonight. Thank you guys so much for joining me. And I'm opening the floor to questions, comments, concerns, anything you want to say. I'm here.
Hi, I just had a general question about how the New York Health Act intends on helping or impacting undocumented immigrants who live within New York, specifically just because I'm sure within downstate, that's like a huge percentage of the population that you probably see.
So to be honest, I don't actually know. I don't know the exact mechanism that the legislation implements that allows undocumented people to sign up. But I know that it does because the other major, like pretty much all, not all, but a majority of the other major organizers for the New York Health Act are people specifically from immigrant activist groups that are like their main reason for pushing for it is because it will cover undocumented people. So I'm sorry that I don't know the exact legal mechanism through which it does that. I just know that it does. We'll have to read on Google the exact way that it provides extensive coverage.
Thank you.
Someone asked if I could share the Bronx district leader. Yeah, if you live in their district, I'll let you know, or they should be reaching out to you sometime in the next couple of weeks to loop you in on the outreach act efforts to your specific person. So the person who asked me that question, I'm pretty sure you do have a district leader, so I'll connect with you in the next couple of days about who that is and how to help them or how to get in touch. Right. So I'll just hang out here till I see that people have left, but thank you guys so much for coming. I really hope to see you guys on Friday. If you don't have Twitter, make a Twitter profile. It's not that hard. It's the tech, like we'll talk about it more on Friday, but like the technique I use is a very different approach from how most people use Twitter, but it works for what we're doing. It works for activism. So you don't need to have a lot of followers. You just need to make a profile that looks like somebody who votes, which means a human that's not like an emoji or a celebrity photo. Thank you guys so much for coming. Thanks for everyone putting, responding to the chat box. Thank you guys so much. If anyone is still listening, my mom just said she'd get Twitter. That's amazing. I love you, Mom. I'll do I'll either me or one of our siblings will teach you. We'll show you how to do it. Yeah, my mom just got Zoom today. She's amazing. All right, everybody have a great night. I'll see you guys later. Stop share.